Greetings. My name is Caldwell Esselstyn Jr., and I direct the cardiovascular disease program at the Cleveland Clinic Wellness Institute. I'm happy to share with you part 3 of our segment on the strategies and treatment of coronary disease called the Nutritional Treatment of Coronary Artery Disease and Nutritional Strategy. Now, this first study that I want to share with you is one of 2 studies I want to brief you with today. This first one began back in 1985 when I went to the Cleveland Clinic Department of Cardiology to ask for approximately 24 patients, which was the number that I thought I could manage and still carry out my surgical obligations. And the whole idea here was to see if we couldn't change their nutrition to remove completely from their diet those kinds of foods that were injuring the endothelial cells, and also the types of foods that sort of matched, in a sense, those cultures on the planet where cardiovascular disease is virtually non-existent or plant-based. Now, I know that I've shared in some of the earlier segments with you the fact that there are cultures on the planet where heart disease is virtually non-existent, namely rural China, the Papua Highlands, Central Africa, the Tarahumara Indians in northern Mexico. And in the 1970s, there were interesting animal studies that were done that where you gave these animals a diet that was very high in fat and demonstrated that there was cardiovascular plaque and disease, and then really reversed and took away the high-fat diet, you could get some regression. Now, therefore, there were these 24 participants. 23 were men. I had nothing against women. This is simply the way the patients came into the study. I think you'll see in the second study there were many more women. The whole idea here was to try to keep their cholesterol at or under 150 and their LDL around 80. And I did not want them to have any of the following foods which were going to adversely impact endothelium. For instance, that's all oil: olive oil, corn oil, soybean oil, safflower oil, sunflower oil, coconut oil, palm oil, oil in a cracker, oil in bread, oil in a salad dressing. Oil will injure the endothelial cell, as does anything with a mother or face: meat, fish, chicken, turkey, fowl, and dairy, milk, cream, butter, cheese, ice cream, and yogurt. I also asked them not to have caffeine in their coffee. Decaf, okay. And the new kid on the block we have to be watchful for is an excess of sugar: maple syrup, molasses, and honey. Here is research that I've referred to in an earlier segment, but I'm going to emphasize it again. And this is research that came out of the Cleveland Clinic Department of Molecular Biology, Stan Hazen and his team. And what they were looking at was the intestinal bacteria's capacity to actually metabolize these animal products that you see on this slide into a molecule called TMA, trimethylamine, which is oxidized in our liver to trimethylamine oxide. And it is trimethylamine oxide that can injure vascular tissue. Now, the exciting thing about this research was that, and here you see the schemata of lecithin and carnitine being converted by gut bacteria in the omnivore to trimethylamine, and then further oxidized to trimethylamine oxide, and then injuring vessels. But if you give somebody who is totally plant-based a lamb chop or a steak, they don't make TMA. Why? They do not possess the gut bacteria. And so this is really a very strong validation for the entire plant-based approach to vascular disease. Obviously, this meat is to direct us to a Harvard study in the School of Public Health when they followed 121,342 individuals, and these were healthcare professionals, followed 28 years. the risk of dying was up 12% with those who were eating red meat on a daily basis, and it was up 20% when the meat was hot dogs, ham, and bacon. Now this is where I'm going to share with you a disagreement. This was a study that came out of Spain in February of 2013 and was reported in the New England Journal of Medicine. And it was entitled "The Primary Prevention of Cardiovascular Disease with a Mediterranean Diet." Now in this study, there were people who had a Mediterranean diet with olive oil, Mediterranean diet with nuts, and then the control group had, for a while, 39% fat, which was referred to as a low-fat group. And anybody who is a professional in nutrition recognizes that 39% or even 37%, which is what they had for a while, is not a low-fat diet. The other thing that was interesting is they started in this study with people who had risk factors, but nobody was to have had a previous cardiovascular event. No previous cardiovascular diagnosis of cardiovascular disease. So when I was asked to comment on this by a reporter from the New York Times, I said, well, I think that the title of the article is wrong. It should be "The Creation of Cardiovascular Disease with the Mediterranean Diet." Now, I said that because, remember, they started with nobody who had this disease, and by the completion of the study in 5 years, there were hundreds of people in all the categories who had had strokes and a heart attack and death. Now, there was no significant difference in any of the three groups with heart attack or death. There was a little bit higher rate of stroke in the ones that were eating what I call the high-fat diet. So it was really a very poorly, I think, orchestrated study that hardly proved the point. And let's move on a little further and see now. Here is the Sydney Heart Study from Australia, where they tried to replace saturated fat in these patients with heart disease with safflower oil, and they found that actually the results were even worse. Now here is a fairly recent study clearly showing how olive, soybean, and palm oil intake have a similar acute detrimental effect over the endothelial function in healthy young subjects. And you'll know if you've participated in our previous presentations on this, that clearly the brachial artery tourniquet test can tell us whether or not a food is injurious to the endothelial cell. Now we're going to shift gears because our approach here is not a no-fat diet. This gives us some idea or grasp of why we're not very enthusiastic about oil. The orange is omega-6 and the white is omega-3. If we start on the left, we have olive oil with a ratio of omega-6 to omega-3 is 11:1. For canola oil, it's 2:1. Peanut, 6:1. Flaxseed. You can see flaxseed is markedly strong in omega-3. And now we would actually ask you not to have the flaxseed oil, but you certainly can have a teaspoon of ground up flaxseed on your cereal to enhance the omega-3. Sunflower, 15:1. Corn oil, 79:1. And soybean, 2:1. Reason we don't want to have this tremendous overwhelming dose of omega-6 is that you want to keep kind of a balance between the amount of omega-6 and omega-3, where the ratio is maybe 1:1, 2:1, or 3:1. But in America, right now, it's something like 17 or even 30:1 of omega-6 to omega-3. And if we look now at the same oils in relationship to nuts and seeds, we see that English walnuts 4:1, black walnuts 16:1, avocado 16:1, pecans 20:1, pistachios 37:1, and filberts 88. And looking at the ratio of nuts and seeds. Further, pumpkins 117 to 1, cashews 117 to 1, pine nuts 300 to 1, sunflower 300 to 1, Brazil nuts 1,000 to 1, almonds 1,800 to 1, and finally looking at saturated fat. In the black, walnuts 5%, almonds and flaxseed 6%, sunflower and filberts 7%, English walnuts and pecans 8%, pistachios 9%, cashews 13%, pumpkin seeds 14%, avocado 15%, macadamia 15%, and Brazil nuts 21%. So I'm not a great fan of nuts for patients who have heart disease, and I'll tell you why. How many of you know somebody who will eat one nut? And if Dr. Esselstyn ever says that you can have 3 English walnuts a day, that's not what people would remember. They'd just say, Esselstyn said that nuts are okay. And in that case, there would be nuts in the glove compartment. There will be nuts in the bathroom, in the bedroom, in the kitchen, in the workbench. Nuts are highly addicting. And we found that when we stop the nuts, we often will get closer to having the biomarkers that we want. So, here you are. You're now eating plant-based. What are the foods that we want you to have? We want you to have all those marvelous whole grains for your cereal, bread, and pasta, 101 different types of legumes, all those marvelous red, yellow, and green leafy vegetables, and some fruit. Now, we have to echo back to part 1 when we talked about what was the nature of the plaque. The plaque actually is made up of this, you recall, this absolute cauldron of oxidative inflammation. So we have to reverse this oxidative inflammation cauldron. How do we do that? We do that through antioxidants. No, do not go down to the health food store and buy a jug of pills that says antioxidant. It doesn't work, and it probably is going to be harmful. I want you to get your antioxidants from food. What food? The food that is high in ORAC value. ORAC, oxygen radical absorptive capacity. What foods are those? Well, raspberries, blueberries, and strawberries, wonderful for your breakfast. But the champ, the absolute champ, are the green leafy vegetables. And now I should share with you that I'm perhaps known as a bit of a taskmaster, but I'm not as mean as I look. So how do you get these green leafy vegetables? I'd like patients with heart disease, especially those with angina, serious heart disease, I want them to have a green leafy vegetable that has been cooked in boiling water for 5.5 or 6 minutes, so it's nice and tender. And then it's anointed with several drops of a delightful balsamic vinegar, so you're having something that's absolutely delicious. I want that alongside your breakfast cereal. I want it again at mid-morning as a snack. I want it again with your lunch and sandwich, again as a mid-afternoon snack, again at dinner time, and I adore it when you have that evening snack of kale. What are you doing? All day long, you are absolutely bathing this cauldron of oxidative inflammation with these very powerful natural antioxidants. And this, we've seen time and again, make really quite a strong difference in how these patients are getting along. And I will agree that it's inconvenient, especially the mid-morning and the mid-afternoon, but when that is done, it really does help in this cascade of eliminating the tremendous amount of oxidative inflammation that accompanies this illness. Now, we have to go a step further, though, because we've constantly emphasized right along the importance of nitric oxide. Now, if we have somebody who's age 40 and they're beautifully healthy, the amount of nitric oxide that is produced by their endothelial cells is now really 50% of what they could produce when they were 25. Now, does that mean that the old carcass is letting you down? No. We have another avenue to make additional nitric oxide. How do we do that? Through the gastrointestinal tract. How do you do that? If I can persuade you to chew nitrates. When you chew nitrates, those nitrates in your mouth are going to mix with the facultative anaerobic bacteria that reside in the crypts and grooves of your tongue. Those bacteria are going to reduce the nitrates in your mouth to nitrites. Now, when you swallow the nitrites, your gastric acid is going to further reduce those nitrites to nitric oxide. The nitrites in your stomach, which did not get converted, further downstream will be reabsorbed into the circulation. And when they circulate back to the salivary glands, they're going to be concentrated 10 to 20-fold. So that now as you chew additional food, your own saliva is pouring nitrites into your mouth, which when swallowed will be further reduced by your gastric acid to nitric oxide. Pretty exciting. No oil. This is just a little breather and a reminder. Too many of those calories. Now, the reason that we start with patients and we don't break them into this type of nutrition slowly is because the Manil chemical census study showed us that when they took 3 groups of patients, one at 34% fat, one at 20% fat, and another one down around 11, 12% fat, where we are, that at the end of 12 weeks, 90 days, one of those groups will have lost their fat craving. They will have downregulated their fat receptor. And that is so key. And that was the group that is down at 11 or 12%. Because if you don't downregulate your fat receptor, then the fat craving is remaining and the likelihood of recidivism is greater. Now this group started with a baseline cholesterol of 237, this group that I shared with you that I started in 1985. And this group, I should tell you that this group were really quite sick. And one of my late brother-in-law used to refer to these as Essie's Walking Dead. They had failed their first or second bypass. They had failed their first or second angioplasty. They were too sick for these procedures, or they had refused. There were 5 who were told by their expert cardiologists they would not live out the year. And those 5 made it all beyond 20 years. Now, the question, though, was how do you get these people to be compliant? Because the rock upon which I was concerned that this study might flounder would be lack of patient compliance. And since I was not a psychologist, I chose to use for these patients the same mantra that I'd used for my cancer patients, that I had learned years ago from a wonderful West Coast surgeon, Bert Dunphy. And Bert had said that patients with cancer are not afraid to suffer, and patients with cancer are not afraid to die. But patients with cancer are afraid of being abandoned by their family or by their physician. So for this first 5 years with these patients, I saw in my office every 2 weeks, these patients, we would draw their cholesterol, look at their weight, their blood pressure, and I would go over every morsel they ate. By the end of 5 years, I got a little bolder and we stretched it out to every month. And then at the end of a decade, by this time they were pretty well on autopilot, we were able to stretch it out to quarterly. And it's interesting that over those first 5 and 12 years, they were able to maintain a total cholesterol under 150. They were able to maintain an LDL cholesterol around 80. And what I want to share with you now are several angiograms. And these angiograms will be showing you some degree of disease reversal. They were all reviewed in triplicate in the angiography core laboratory of the Cleveland Clinic by senior technicians who do this all day long for national medical trials. So that when I give you a certain percentage of reversal, I'll know that it's accurate. This first happened to be the left anterior descending coronary artery in a 67-year-old pediatrician. And the improvement here is on the right, where you can see that it is wider by a small amount than it is on the left. it's a little easier to see in this next one, where we're now looking at the circumflex coronary artery in a 58-year-old factory worker. And this improvement from the left to the right was described as 20%. This next happens to be the right coronary artery in a 54-year-old retired security guard. And this, again, shows improvement from the left to the right of 30%. Now, on the other hand, this happens to be the gentleman who was in the first chapter of my book. This is a colleague, Joe Crow. Joe replaced me as the chairman of the breast cancer task force at the Cleveland Clinic. It was in 1996, with a cholesterol of 156, not a smoker, regularly exercised, no family history, not hypertensive, not diabetic, that Joe began getting chest pain. In the summer of '96, he saw cardiology in October. They worked him up, could find nothing wrong. The third week in November, he finished his surgical schedule and he sat down to write postoperative orders. He got suddenly this splitting headache, immediately followed by this crushing chest pain, with pain in his left shoulder and arm. He was having a heart attack. He was whipped down to the cath lab. And at that time, the entire lower 1/3 of his left anterior descending coronary artery was moth-eaten and diseased, over too long a segment to permit the use of stents, and it was too far down the artery to allow for bypass. So Joe was very depressed about this. And 2 weeks after his heart attack, my wife and I had Joe and his wife out for supper. And I simply said, Joe, look, you've been eating this horrible Western diet. You've got the typical Western disease. Why don't you think about going plant-based? We've got 10 years of data. And he said, okay, yes, I'll give it a shot. They couldn't offer me anything else, but I'm not going to take any of those statin drugs. I simply don't trust them. I hear there are too many side effects. I said, fine, that's your call, no problem. He became the absolute personification of commitment to plant-based nutrition over the next 2.5 years. At the end of 2.5 years, up in the surgical office area where our doors are 3 doors apart, I found myself at noontime of the day that I knew that earlier that morning Joe had had his follow-up angiogram. I walked over to the office and let myself in. There he was sitting behind his desk. And I simply said, Joe, how did the angiogram go? And he walked over and gave me a hug and said, I think we're doing okay. I said, well, any chance that I could see the follow-up angiogram? And he said, yeah. So it was really quite dramatic. And occasionally when the plaque seems to be young, when the plaque is made up largely of fat, inflammation, and cholesterol, the body can do a rather remarkable job of restoring and remodeling. And although this is the type of reversal that is kind of jazzy and dramatic, I really want to spend some time when we get to it on other types of reversal because it's so key to people understanding how this can be effective. Now, what we're looking at here is a PET rubidium dipyridamole scan of the heart. Translation, as you can see on the left, if the heart is looking yellow or orange, that means it's good perfusion. On the left, you can see in the middle, where it's green, that is poor perfusion, as seen in this 58-year-old school bus driver from Youngstown, Ohio, who came to us with a cholesterol of 261, but he was counseled at the time that he had this first scan. In 10 days, his cholesterol was down to 126. 6 weeks later, it was repeated, and now he had all this restored. Now, what in the world is going on here? Here's another gentleman. This is a 60-year-old stockbroker from downtown Cleveland who came to us with a cholesterol of 248. At the time of his scan on the left, it should look like a nice donut. Well, here you can see on the right side where that band of green clearly demarcates the place where there's poor perfusion. But he also was counseled and got it. and within 10 days, his cholesterol was down to 137. Then, 3 weeks later, not 6 weeks later, 3 weeks later, the scan was repeated, and now he had it restored. Now, in neither of these did we ever really fully wash out all of that plaque. How did they get this tremendous restoration of flow? Why do these patients get rid of their chest pain within this rapidly? So let's look to define this further at this angiogram, where in the left main coronary artery, just before it bifurcates into the circumflex and the left anterior descending, this gentleman had an 80% blockage. It was felt rather hazardous to try to do any type of angioplasty or stent here, because if they was an adverse outcome, the entire blood supply to the left heart would have been lost. So he was scheduled for coronary artery bypass surgery. But at the time that he was scheduled in September, he was told by the surgeons that they were backed up and that they could do him in December. So I had the opportunity to see him in early October of 2005. And I should share with you that this is a triathlete. He was 53 years old, but he'd gotten so compromised that he was getting angina just walking to the mailbox. Well, he happened to see us in that first week in October, and this guy just totally got it right. Within 11 days, his angina walking to the mailbox had disappeared. But this is a triathlete. If he had been a shopkeeper, I would have had him cured in 10 days. But here's a triathlete, and he tries to walk fast or start running and gets a little discomfort or pain. But he ended up canceling any surgery, and it took us 3.5 years to get to the point where he could stand up on the pedals of his bicycle going up a steep hill, hammering as hard as he could without getting any chest pain. And he continued to do this, and I recently saw him now 9 years later, when he had just returned from hiking in the Andes Mountains above Machu Picchu, 16,000 feet. No chest pain. Now the interesting thing is, a year or two ago, he went to a cardiologist in Rochester, New York, who thought it was time to repeat the angiogram. And it was. And guess what? There was absolutely no difference. In other words, in some of these patients where the plaque is old, made up of scar, calcification, fibrosis, there may be some remodeling, but it doesn't go away. But why do those previous two patients that I showed the scan on and this patient absolutely make the point that I'm trying to share with it? When you restore fully the capacity of the endothelial cell, the entire coronary artery tree, which previously was unable to dilate because there wasn't sufficient nitric oxide, now all those normal vessels throughout the heart, which couldn't dilate before, can dilate, as well as even those that are diseased can dilate. So that these patients, obviously then, when they stick with it, can successfully return to full activity without restriction when they've gone through plant-based nutrition. Pretty exciting stuff. So if we summarize the patients that we've talked about, and the goal that we seek here is obviously on the left, the cap over the plaque is really very thin at the top. But as somebody eats plant-based, the plaque remodels, and look in the center, you can see how thick the capsule is over the plaque. And when we get to the far right, you can see that absolutely now, that plaque is rupture-proof. Now, we should talk a little bit about, despite my sparkling personality, there were 6 of these original 24 patients, nice guys, but they just didn't quite get it. And I had no money for this study, so they were released from the study after 2 months and returned full-time to their expert cardiologist. They became sort of a quasi-control group. But I followed them, peeked in from time to time to see how they were doing, and at the end of 12 years, 2 of those 6 who had dropped out had died, and the other 4 had to have a bypass operation. Now, what about those other 18 that stayed with us? The 18 that stayed with us We wanted to know, while they were in the care of expert cardiologists, during the 8 years before they ever came into the study, they had these 49 coronary events, which are dispersed among the categories of worsening disease that you see up here, ranging from increasing angina, angiographic disease progression, bypasses, heart attacks, strokes, the need for angioplasty, and a worsening stress test. However, once those 18 patients came into the study, over the next 12 years, 17 of those 18 had no further events. Yes, at 6 years we did have one little sheep who wandered from the flock, got into the lamb chops and the glazed donuts, got angina, had a bypass, but now he is back with the flock, and in other words, proves the point that I'm trying to share with you today. Now, there have been some other really massive studies to try to show that there can be a benefit to nutrition in heart disease. Obviously, when you do a massive study, it's not going to be quite as assiduous, perhaps, as when you are working with a smaller group of patients, but this was a study that was reported in circulation worldwide of 31,546 participants. And the authors graded the quality of the nutrition into what we call quintiles. And when they compared the best quintile to the worst, there was a 35% lessened likelihood of death, a 14% lessened likelihood of myocardial infarction, and a 19% lessened likelihood of stroke. Now, on the other hand, here's what can happen when you really do look at what can occur when a nation decides to pull up its socks and get smarter about heart disease. This is Finland. And in 1972, Finland was really at the bottom of the barrel. They had the highest rate of heart attacks among their men between the ages of 35 and 64 of anywhere else on the planet. And the green line that you see here at the left is in 1972. And you can see by the time we get to 2005, almost 30 years later, in North Karelia, where they started this project, heart disease was reduced by 85%. Profound. Enough was happening there so that the rest of Finland in 1978 decided to get on board, and that's the black line. And you can see how by 2005, they and the entire nation of Sweden reduced their heart attack rate by 80%. That's enormous, but it shows the capacity of what can happen when people are instructed to eat much less animal fat and to stop smoking. And here you look simply at the subject of cancer, and their cancer rate was reduced by 67%. A great deal of that, of course, was lung cancer reduction because they were asked to not smoke. Now, here is another study, this time out of the United Kingdom, of 44,000 participants. What was particularly interesting here was that 15,000 of those 44,000 were vegetarians. And they described a vegetarian in this study as somebody who didn't eat meat or fish. And when they compared the results of those who were vegetarians to those who were not over an 11-year period, they found the vegetarians experienced a decreased body mass index, decreased blood pressure, decreased cholesterol, and a decreased likelihood of ischemic heart disease of 32%. Now, I want to move now into a second study. Now, this to me has been very exciting because I think we were rightfully criticized with our earlier small study that, okay, so you showed that you could reduce the likelihood of heart disease and you could actually reverse disease, but could you actually get a larger group to comply? And would the results be the same? So what I'm going to share with you now is our new manuscript that will be published actually in 27 days by the Journal of Family Practice. That is, it's coming out in July of 2014. Now, in this group of some 200 patients, 2 were lost to follow-up. You'll notice here the thing that just really stands right out is that 89% was the likelihood of our compliance. And that was, we thought, very exciting. And many people have said, how in the world can you get 89% compliance when you're asking people to change their entire nutrition and lifestyle? And I think the reason that this happened is twofold. One, we usually conduct a very intensive counseling seminar for these patients with groups of usually between 10 and 12, and we insist that the spouse or the significant other be in attendance as well. Now, usually about 10 days or 2 weeks before we have the seminar, my secretary will give me a list of these patients and their phone numbers. And I insist upon getting in touch with each of these patients myself so that I can get my arms around their story, and at the same time, they will have an opportunity to ask questions of me so that when they do come to the seminar in the next 10 days, we'll have a strong platform from which we can move forward. Now, I've mentioned before that I think the way to get compliance is to show a patient respect. And the only way that I know to really show a patient respect is to give them our time. We want to make this the most significant interchange that they've ever had with a caregiver. We're going to give them not only that conversation over the phone before they come, but 5.5 hours of our time. They have to register in their head that if the physicians feel that this is so important, that they're spending this amount of time with us, this must really work. And I'll share with you that what we talk about at the seminar is exactly what they have done that created this illness in the first place, and precisely how they can become empowered as the locus of control to halt and reverse this disease. And in addition, they receive a very hefty notebook, a notebook that has within it, every one of my slides is going to be in that notebook. That is every one of the PowerPoints. They're going to have several of our scientific articles, a 44-page handout that has many additional recipes that combine with the 130 which are in my book, which we include. There's also going to be an hour-and-a-quarter presentation from a woman who has had 30 years of experience acquiring and preparing plant-based dishes, dealing with reading ingredients, dealing with travel, and dealing with restaurants. Then we almost invariably will have a DVD for everybody that is of the entire seminar that we filmed from an earlier one, so that if they go home and get a little rusty or forgetful, they can flip this on and get themselves back up to speed. Then we always will have 1 or 2 local or regional participants who've had a previous successful experience share their story, because our participants say that there is nothing that is as compelling or profound as hearing from patients who have been through this, who have successfully had an outcome that everybody can be proud of. And then we answer questions and have a delightful plant-based meal and stay in touch as necessary, either through email or phone call. All right. Now, so we had 177 patients who were compliant or adherent, 21 who weren't. Now, how do you know that these patients even had heart disease? 180 of them had angiography, 74 failed their stress test, and 44 had already had a heart attack. There were 161 that had hyperlipidemia, 60 with hypertension, 23 with diabetes. I mentioned the 44 with a heart attack. And the results, 144 improved, reversed 39, stable 15. And what about disease progression? We had 2 patients. One had a small stroke in China when he really was not with the program, and one patient required coronary bypass. Of the 5 deaths, none were cardiac. There were 3 from cancer, 1 a pulmonary embolus, and the other pneumonia. Now, what about the patients who were non-compliant? Of those 21, 8 stable, 13 got worse. 11 of those 13 we divide into the categories of 2 had a stroke, 4 had a stent, 3 had a bypass, 1 had an endarterectomy of leg disease, and 1 heart transplant. And of the 2 deaths, both were from cardiac disease. So for recurrent events, there is 1% in those who were adherent, non-adherent, 62%. Now, again, the severity index. 119 of these patients, prior to our even seeing them, had already had a bypass or a stent. And 27 of these patients, for whom a stent or bypass was recommended, found that that it was unnecessary to have that intervention after they had had this counseling. Of those patients who had reported angina at baseline were 112, and 104 or 93% had that improve or resolve. And totaling the benefits in the adherent participants, disease reversal 22%, angina improved or resolved 93%, weight loss around 18 pounds, avoidance of recurrent cardiac events 99% over the 3.75 years. Now, this is an interesting way to put this bar graph, because if we look at percent who have had major cardiac events, if we look on the far right first, if we look at the Mediterranean well-known Lyon heart study, at 4 years, 25% had recurrent major cardiac events, death, heart attack, and stroke. For the natural history of heart disease out of Columbia Presbyterian Hospital, that was 20.4%. And for Courage study of Bill Bowden, that was 19%, roughly somewhere around 22% major cardiac events. Then we look at the far left at ours. When you treat the cause of disease, 0.6%, that is, we had 1 stroke that we mentioned. So it's truly profound and exciting what can happen when you treat the causation of this disease. And what we're going to talk about is that the mortality from this diet is unknown. No morbidity from the diet. In other words, if you compare this approach, you compare this treatment to all the drugs and the bypasses and the stents that are done today, there's no contest between the expense or even the morbidity and mortality. And all that happens with the passage of time is that the benefits continue to improve. And most importantly, these patients are empowered by the knowledge that they are in control of the disease that was destroying them. In other words, patients with heart disease today are walking around with a sword of Damocles hanging over their head, wondering when it is that the other shoe will fall. Well, it never has to. These patients are so empowered to know that if they do this, they can make it so that their plaque cannot rupture, and they can make themselves heart attack proof. Now, not everybody should be asked to do this. We know that there are tremendous differences in physicians for competencies for prescribing lifestyle medicine. For instance, pathologists perform a wonderful service, but there they are looking at slides and dead tissue. They never have to converse with their patients, but an enormous contribution. Sometimes radiologists don't have an opportunity to speak very often with their patients. So that, again, just as there are other specialties in medicine, so there are going to be specialties for those who are prescribing lifestyle medicine, who enjoy the opportunity to have an interaction with their patients to try to get them to change to a healthier nutritional literacy. And I want to say that our next segment will be the nutritional treatment of coronary artery disease and nutritional strategy beyond coronary artery disease. Thank you.